Is that the proposal is for this tapering to go to 0, but I'm really focusing on mandated opioid tapering. And so I came here to review the evidence with all of you and also to offer an option to address the current needs for best practices in patient care, individuals who are living with chronic pain who are taking long-term prescription opioids. The fundamental issue is that patients taking long-term prescription opioids for many years and even decades require different considerations and care pathways than other patients for whom they may not be taking opioids, or maybe they've just been taking them short term. So the issue at hand really focuses on patients who've been taking opioids long term, what I sort of call legacy prescriptions. The evidence to date is limited because it does not directly apply to the current population under consideration for these mandated tapers. And I just want to review a couple.
Unplugged over here. On the ground, behind you. Okay, you're off.
Hello? Hello, hi. So I just want to review some of the evidence that it's been uploaded and sort of more speaking to the benefits or efficacy of opioids, but I want to describe why these guidelines and why these studies are ill-equipped to actually inform anything about opioid tapering. So the first is the SPACE trial, and this is often quoted and cited, and it's an excellent study. I know Dr. Krebs, she's an amazing researcher, very well respected, but the issue is that it's a prospective study of de novo opioid prescribing. It does not inform best practices for opioid tapering at all, because that was not the focus of their study. The CDC guidelines, 2016, everyone is very well aware of the CDC guidelines. They report considerations for new prescriptions. They recommend close monitoring of new prescriptions and also discontinuation in cases where that monitoring is revealing that the opioids are not benefiting the patient. The CDC guidelines offer no guidance for best practices in tapering legacy prescriptions and addressing the needs of this specific segment of our patient population. There was a study that was uploaded, it's Frank et al. This is a meta-analysis of multiple different studies that looked at opioid tapering. The issue with the Frank study is that when you take a look at all of the studies that they included in the meta-analysis, there's a wide variability in the methods that the studies used. And in fact, only a few of those studies focus on patients going to zero opioid dose. And of those studies, they really don't apply to the Oregon Medicaid population. And the reason is that they received services that are really not widely available here, such as intensive inpatient rehabilitation, Suboxone support, and what is called sort of chemical detoxing. These services are not available, it's not directly applicable. None of the outpatient studies went to zero opioid dose. In fact, when you look at the outpatient studies that are most applicable to the Oregon Medicaid population, those patients reduced their opioid dose by 40%. And that's when they received behavioral support, such as the cognitive behavioral therapy and other treatments. So again, these data suggesting that the current proposal are too aggressive if we want to reference the evidence base. It does not support it. Lastly, my study conducted by my group, Darnall et al., this was published in JAMA Internal Medicine earlier this year. This study was conducted in patients who wished to reduce their opioid dose. And so this is a voluntary study, and all of my methods are focusing on patients who wish to reduce their opioid dose. Now, we recognize that sometimes this term voluntary is elusive because physicians in the community may be essentially saying, look, I need you to reduce your opioid dose, or this is the guideline. But when they come to us, we're not forcing them to do anything, in fact. We provide them with a safe and compassionate structure so that they feel secure in being willing to try to reduce their opioid dose. All of our methods are focusing on partnering with the patients and helping them feel as much control as possible in this process in which, again, they have agreed to partner. So if individuals wish to pause the taper, if they need to move at a slower pace, or if they wish to stop the taper altogether, we do not force them down any particular care pathway. Our goal is to nurture them forward to the lowest comfortable dose for each individual person. Now, when you take a look at our JAMA internal medicine study, on average, individuals reduced their opioid dose by 50% over 4 months. But here's the thing, there was wide variability. A few patients increased their opioid dose. Some patients did go to 0 in 4 months. But the point is that our program and the outcomes were individual. And this underscores the importance of having clear flexibility in programs and policies so that we're best treating each individual's patient's needs. Now, you may ask me, how did you get patients to volunteer to reduce their opioids? Well, the truth is, there is a segment of patients who wish to reduce their opioids, but they've never been offered a compassionate pathway to do so. Others may have heard about the risks of opioids, and they want to reduce them, but again, they don't know how. We discuss with our patients the potential benefits, and we emphasize close support and care. We're actually offering them better pain care because we're monitoring them so closely and in a way that they have never received before in traditional pain care pathways. So finally, I just wanted to present some consensus data from the Veterans Administration. So this is through the VA system. And the latest consensus that was put forward by Freedom Sandbrink, and he is the acting director of the National VA Healthcare System. He states strong caution for involuntary tapers as they carry significantly greater risk than voluntary tapers. They interfere with collaborative provider-patient relationships and the shared decision-making models that we know help our patients achieve best outcomes. Medical and psychological destabilization can occur in forced opioid tapering, leading to patient distress and other harms. Increased suicides are reported, and these are even at relatively lower doses. There's a false perception that opioid overdoses, and in particular suicide risk, increases with the higher doses. The data from the VA are showing that 80% of suicide decedents had opioid doses below the CDC recommended threshold, suggesting, again, that lower opioid doses do not confer a degree of safety, that it's this destabilization in the process that is one of the greatest risks at hand. Medicaid recipients may have even greater vulnerability due to lower socioeconomic status, fewer resources, greater medical complexity, and greater mental health needs. The EMPOWER study is funded by the Patient-Centered Outcomes Research Institute. I mentioned to you that this is active in 4 Western states. This is voluntary, patient-centered opioid tapering program. A key component of the EMPOWER study is that we train prescribers, physicians, nurses, physician's assistants, how to implement our methods that are patient-centered and, again, focused on helping craft an individual taper program that maximizes patients' sense of control and actual control in the process. Once patients enroll, we track them closely. We deploy surveys to them weekly to understand their response to the taper, to ascertain whether they're having difficulties, whether they're experiencing any withdrawal symptoms, or anything else that we need to triage. We offer them close clinic follow-up if needed. Of these 900 patients who will be agreeing to reduce their opioids, we're randomizing them to one of 3 groups. One group is 8 weeks of group cognitive behavioral therapy for pain, so that's led with a psychologist. Another third of our patients will receive 6 weeks of peer-led chronic pain self-management program, and the other third of our Empower patients just receive our patient-centered taper only. Because there's a lack of data on how to best reduce opioids, our study, the Empower study, is designed to collect these information to inform best practices for safe and humane care. Once we have these information, we will inform pain care nationally. I mentioned that the Empower study is in 4 states, and we're studying almost 1,400 patients in total. I can offer you this program for Oregon if you wish to carefully study a group of Medicaid patients who wish to voluntarily reduce their opioids. I'm willing to share the information with you without any fee for my time. This is an opportunity to collect your own evidence about how to best help a select group of Oregonians, those on legacy opioid prescriptions who require special care pathways and for whom no evidence exists, direct evidence for tapering, but evidence does suggest risk for harms. I applaud the board for placing attention on the fact that society is at risk and measures must be taken. I'm advocating for this specific segment of the Medicaid population, patients taking legacy opioid prescriptions. These patients are underserved and have complex care needs. Evidence is lacking for forced tapering, and no outpatient studies exist for a zero-dose mandate. To avoid risks and harms, careful and patient-centered approaches that study the issue in voluntary tapering could help inform your decisions in creating effective policies that are rooted in best practices for pain management. Thank you.
How long is the study?